Hello everyone, we're going to start our lecture on congestive heart failure. We're going to be focusing primarily on the fundamentals of understanding an ALS treatment. So before we begin this lecture, I'll first introduce myself. My name is Jacob Bryan. I'm a North Carolina paramedic, currently work at North State Medical Transport and Johnson County EMS. I'm also currently in Wake Tech's Paramedic Associates Bridge program. I'm a former EMT for about 3 years. During that time, I worked at North State Medical Transport as an EMT basic preceptor, along with a fill-in FTO. So now that you guys know who I am, we can go ahead and get started for our lecture. First, we're just going to go over the lesson objectives. There's going to be 5 objectives. At the end, we're going to be taking a lesson assessment. If you pay attention to everything we talk about in the lecture, watch the videos, you should do fine during the assessment. So the first objective, students will explain the cause of CHF and the effect it has on the human body for at least 75% accuracy in a written assessment. Objective 2, students will accurately recall signs and symptoms of congestive heart failure and differentiate the acuity of symptoms with at least 75% accuracy in a written or online assessment. Objective 3, students will remember the congestive heart failure, pulmonary edema, NCOEMS state protocol and apply it with at least 75% accuracy in a written or online assessment. Students will then show competency through completing low fidelity simulations without critical error. Objective 4, students will interpret the patient's acuity level and create a competent treatment plan for at least 75% accuracy in high fidelity simulations without critical error. Then finally, objective 5, students will identify deterioration of a CHF patient and modify the treatment plan to stabilize the patient for at least 80% accuracy in high fidelity simulations without critical error. So to start our lesson off, first we're going to be talking about congestive heart failure's anatomy and physiology and the effect it has on the body. This is going to be going over objective 1, where students will be able to explain the cause of CHF and the effect it has on the human body with at least 75% accuracy in a written or online assessment. So first off, what is congestive heart failure? So congestive heart failure, also known as a chronic heart failure, is a dysfunction of the heart's ability to pump adequately. Depending on the type of heart failure, whether it's right-sided or left-sided, can cause backflow to systemic circuit or the pulmonary circuit. It is commonly due to drug use, hypertension, COPD, and MI. 500 diagnoses every year in the United States, so it is very common. 50% of those 500 diagnoses actually have a 1-year prognosis, so it is a pretty high mortality rate with CHF, and it is the leading medical cause of death in the world, along with other heart diseases. So like I said, there is the left-sided and right-sided heart failure. We're going to first talk about left-sided heart failure. It is the more common heart failure you see whenever you have CHF patients. It's caused by damage to the left ventricle, caused by increased pressure to the left atrium and pulmonary veins. The increased pressure in blood causes fluids to leak into the capillaries, into the alveoli, causing that pulmonary edema and crackles. You also get the hypoxia and diaphoresis is very common and usually good indicator there it is left-sided heart failure that is going on. You can also have a sympathetic nervous response causing bronchoconstriction, hypertension, and tachycardia. Treatment for left-sided heart failure includes CPAP, nitroglycerin, enalapril, Lasix, and then there's some more that we'll discuss later in the lecture. So now going into right-sided heart failure, this is when the blood pools behind the right ventricle and increases the pressure in the systemic veins. As right-sided heart failure does progress and cause fluid to leak from the veins into the tissue, causing edema. You'll see the pedal edema in the feet, hands. It also can end up going into the abdomen and other areas depending on how bad the right-sided heart failure is. Usually it's due to the increased workload of the right ventricles due to left-sided heart failure. So it is very common that someone has a left-sided heart failure at first. They, whether it's just really bad or they don't take care of it, they're not compliant with their meds, can evolve to having the left and right side. So like I said, usually it starts off left side and ends up being both. Some good indicators of right-sided heart failure is JVD and pedal edema. So looking for that jugular vein distension, just because of the increased pressure throughout the body. And then treatment for right-sided heart failure is to remove excess sodium and water from the body. So even though we can do enalapril and we can do Lasix, this isn't something that's going to be treated there. Where the actual root of the problem of right-sided heart failure is the edema throughout the body. So it's something that they're probably going to have to be in the hospital for a while, taking Lasix for, maybe long term, at least a couple weeks, just to get all those fluids and salt off the body. So along with the left-sided and right-sided heart failure, we also have the systolic dysfunction and diastolic dysfunction. Felt like this picture was a great example of it. So you see with the systolic dysfunction, it causes the heart to shrink and thin, while the diastolic dysfunction can cause the heart to enlarge and thicken. Both of them have the issues, being able to get blood through the heart, but it is a nice diagram here to be able to kind of see exactly what we mean whenever we say the systolic dysfunction shrinks and thins the heart, while the diastolic dysfunction obviously enlarges and thickens it. Then this slide here, it's a Venn diagram, just showing, the differences between left and right congestive heart failure and also the similarities. Obviously, on this Venn diagram, we're not covering every symptom that is different and alike, but kind of the big things that you could see that might be able to help lead you one way or the other. Obviously, it is a little difficult as well, because most people with right-side heart failure also have the left-side heart failure. So we'll just talk about it real quick. Left-side heart failure, big indicators is the pulmonary edema, the increased respiratory rate and crackles. On the other hand, right-side heart failure, you see the pedal or peripheral edema, ascites, and jugular vein distension. For both of them, though, you usually will see that increased heart rate, increased blood pressure. The patient will also have some weakness and possible confusion, and then they usually will both have chest pain. So in this slide, we're going to be talking about congestive heart failure's effect on the respiratory system. The most common effect it has is it causes rales in the lungs, and this is due to fluid buildup in the lungs. It is very common in congestive heart failure and acute pulmonary edema. This is due to the heart's inability to pump blood from the pulmonary system, and it causes fluid leakage into the lungs. Obviously, having all that fluid in the lungs, it does cause oxygenation dysfunction, leading to hypoxia. And severe progression of CHF can also cause wheezing due to the sympathetic nervous system's vasoconstrictive effects. The lungs are doing probably just as bad as the heart whenever CHF exacerbation is at its severe, moderate, or even to the point of a cardiogenic shock. So for this slide, we're just going to be talking about the effect congestive heart failure has on the cardiovascular system. Obviously, it's the heart failing, so it's a good bit that the cardiovascular system is affected by. The blood buildup and difficulty pumping can cause the heart to increase blood pressure to compensate, which with many CHF patients who already had the hypertension, the CHF exacerbation can worsen it even more so, putting the patient in a very critical position. It can also cause other heart and vascular diseases along with other deadly arrhythmias, and tachycardia can also occur to compensate for inadequate pumping. To continue on, whether causing the CHF or due to a myocardial infarction, heart tissue death occurs due to the inadequate oxygenation of the heart. It can also lead to cardiogenic shock if not treated in time. ST elevation can also be present with the myocardial infarction, sometime being the cause of a CHF exacerbation. Now we're going to look at the body and the effect CHF has on the integumentary system. It causes that peripheral edema, fluid buildup around extremity tissue due to the heart's backflow of blood and fluid due to inadequate pumping. It can also cause the pale, cold, and diaphoretic skin, and also it can cause ascites from the fluid discharge going into the peritoneal cavity. Now this slide is talking about the neurological effect that congestive heart failure can have on the body. Obviously, this is not something that's happening to the brain, but the chest pain, the crackles, the hypoxia due to the inadequate oxygenation of the blood can lead to some pretty serious neurological effects. So some big ones is anxiety and restlessness. This can be due to the hypoxia and shortness of breath from pulmonary dysfunction, along with the chest pain. So see agitation and confusion with CHF patients. Now, some of this could be a mental effect symptom, like, it's just patient can't breathe, we're putting a CPAP on them, or, they feel like they're about to die. Whether that's a previous history of anxiety or just it's a lot going on for them. It's not a good day if your CHF is acting up. But it can also be a medical dysfunction. If a patient is not getting adequate oxygenation to their body, That also means their brain isn't getting good oxygenation, so it can kind of cause some confusion, like I said, some weakness, even agitation, just because they are out of air and their body doesn't like it. So, the sympathetic nerve system kicks in, that fight or flight, and they might be a little aggressive. Understand, it's not that they don't like you, it's just, their body is just fighting and doing everything it can to try to, be okay. So the vasoconstriction, the afterload increases due to the sympathetic nervous system response. So along with the confusion and anxiety, you have that fight or flight system in full effect usually. So in this part of the lesson, we're going to be going over mild, moderate, and severe CHF exacerbation. This part is going to be covering Objective 2, where students will accurately recall signs and symptoms of congestive heart failure, differentiate the acuity of symptoms with at least 75% accuracy in a written or online assessment. So first part is obviously mild CHF exacerbation. It's going to be the lowest acuity of the ones we're going to be discussing. So this is just kind of the beginning of when the heart is starting to have some difficulty pumping effectively. Usually with mild CHF exacerbation, it has a normotensive, so that's a systolic blood pressure of at least 90 or 100 with a regular heart rate. So heart rate between 75 to 100. Early exacerbation of CHF can present somewhat mild, as I said, because the blood pressure is good, the heart rate isn't too high either, but it can still have some dangerous symptoms such as shortness of breath, crackles, chest pain, and edema. So, like I was saying, it might not be that bad starting off, but if these symptoms aren't taken care of, it can lead to moderate or severe CHF exacerbation, along with just some hypoxia, which can still affect a patient pretty well, even if it is not a cardiac issue. So like I said in the last slide, the mild CHF exacerbation can lead to moderate CHF exacerbation. In the North Carolina protocols, they have it as moderate or severe. So this part is when the heart is having severe difficulty pumping blood to the heart and is putting the body at hemodynamic risk. It can progress very fast. It's usually been going on for some time without medical attention, whether that's they haven't gone to the doctor to change their medication, they haven't had the money for their medication, they've never been diagnosed with congestive heart failure, or they've just been straight up non-compliant with doctor's advice on how to manage their congestive heart failure. Now, these do have life-threatening symptoms that could lead to cardiogenic shock if it does not get treated fastly by EMS or by a hospital if they do decide to go by themselves. Some of these symptoms are hypertension, tachycardia, crackles, chest pain, and altered mental status. Whenever we're going to a high acuity congestive heart failure, this is usually the state they are in. As you know, once we get there, we're going to want to treat them as soon as possible to give them the best care and hope they don't go into cardiogenic shock. So like I said, usually in EMS calls when we're going to a high acuity CHF call, this is for moderate or severe per NCO EMS protocol CHF exacerbation, because we want to get there fast, do treatments even faster, so a patient does not end up into what we're about to talk about now, severe CHF exacerbation or cardiogenic shock. So this is not the pumps having difficulty, this is pretty much pump failure. Cardiogenic shock, it decreases stroke volume, cardiac output, and blood pressure. So pretty much everything the heart needs to be able to get blood to the body and get it from the body to oxygenate. It does occur in 5 to 10 AMI patients. Even with aggressive treatments, we're doing everything we can for this patient. It still does have a 70% mortality rate. So that is a big reason why, we want to do everything we can so we don't get to this point. But unfortunately, EMS, it's a lot more of a not a what, but a when situation. So it does begin usually with the compensation. You can also see that with the moderate CHF exacerbation, where they have the increased heart rate, increased blood pressure, tachycardic, hypertensive. But in cardiogenic shock, usually the good indicator of that is it starts off high, then it gets really low. So then it deteriorates into hemodynamic failure. You're having the altered mental status, you're having the decreased heart rate and bradycardia, you're having the hypotension with the decreased blood pressure. So like I said, this is a very serious, very high mortality thing that can happen to a patient with CHF, so we want to do everything we can beforehand to make sure this patient does not get to this point. So we're going to go ahead and take a 5-minute break. If anyone has any questions they'd like to ask me, go ahead, you can do it at this time. If you need to go to the bathroom, get some water, use your phone, whatever you need to do, go ahead, take this 5 minutes, and then once we get back, we're going to go into more of a CHF assessment and treatment in the pre-hospital setting. Now that we talked about what congestive heart failure is, what it does to the body, some of the signs and symptoms and acuity levels of congestive heart failure, we're going to go into the assessment and treatment of it. So objective 3, we're going to be diving into how students will be able to remember the CHF, PE, NC, OEMS state protocol and apply it with at least 75% accuracy in a written or online assessment. Students will then show competency through completing low fidelity simulations without critical error. So this is the NC-OEMS congestive heart failure and pulmonary edema protocol. It would be nice if you guys, if you can't see it greatly on here, to at least have a physical or a digital copy on hand. You can find it online by going to the NC-OEMS website, and from there you can find the protocols in that website. So this is the CHF pulmonary edema protocol. We're going to go over it a little bit in the next couple slides. To add on with the protocol, this page is the pearls. If you want to look at the main protocol or the pearls just to get a better look at it, you can obviously just pause the video and do that. So big things is avoiding nitroglycerin with patients who take erectile dysfunction meds. Always want to consider a myocardial infarction in patients with congestive heart failure. And then more things, you can look through it and it kind of goes in a little bit deeper into different things that might happen with a congestive heart failure patient. So now we're going to be talking about the mild CHF exacerbation. We're going to be going off of the NC-OEMS state protocol. So mild CHF exacerbation is stated as a normal heart rate, the normal or elevated blood pressure. You can also have some minimal crackles in all lung fields. So treatment for mild CHF exacerbation for any cardiac patient with chest pain or anything cardiac related, you want to go ahead and do a 12 lead and interpret that 12 lead as well to make sure they're not having a STEMI or other myocardial infarction. You want to go ahead and oxygenate this patient. Their SpO2 might be a little low. Even if it's not, with the history of CHF, putting a nasal cannula on would probably be a good idea, or a non-rebreather. Doing the CPAP also as needed. You want to be careful, you don't want to shoot their blood pressure down, but if they are having some crackles and you feel like they will benefit from the CPAP, by all means, as long as the patient's okay with it and you think it will benefit their health, go for it. You can also do a lung sound assessment, just to make sure that it is, like I said, crackles, or if it's clear, to figure out kind of what part of the mild CHF exacerbation there's at. Because, like I said, even though it is mild, there's a high chance that it can develop to become moderate or severe. Then you want to go ahead and take care of that chest pain. So every chest pain, obviously you want to give that 324 milligrams of aspirin, but then from there, per congestive heart failure pulmonary edema protocol, you can go ahead and go to that nitroglycerin. So you do the 0.4 milligram nitroglycerin SL, do that every 5 minutes as long as the systolic blood pressure remains above 90 to 100. Same thing with the nitroglycerin paste. You can apply that onto their skin as long as the systolic blood pressure is over 100. We're going to go a little bit deeper into the exact measurement and dosing of nitroglycerin in a couple minutes. So moving on, we're going to go to moderate to severe CHF exacerbation per the NC-OEMS state protocol. This is presented with the elevated heart rate and blood pressure, along with crackles upon lung sound assessment. So this is when the CHF gets pretty serious and you need to start doing interventions as soon as possible to help prevent this patient from going into cardiogenic shock. So like I said, with the last acuity level and any other cardiac call or cardiac possible issue, you want to go ahead and do a 12-lead interpretation to make sure the chest pain and everything else is not a STEMI myocardial infarction or a deadly arrhythmia. You also want to go ahead and do a lung sound assessment, make sure that it is crackles or, some moderate to severe CHF exacerbation can have wheezing, especially if it has progressed for a while. So you want to listen to all fields of the lungs, upper lobes and lower lobes, see what you can hear. At first, you probably be a good idea, or have fire if you can talk to them if you're on the way and they get there before you, to at least go ahead and put on a nasal cannula or non-rebreather. Their SpO2 will likely be low, they will be hypoxic. So before you make the decision to do CPAP, getting them on some oxygen first would be a really good idea. So then, leading to that, once you get there, once you're able to determine it is moderate to severe CHF exacerbation, it's a good idea to get that CPAP as soon as possible. This is because it will help push down the fluid, be able to help the heart and the body get oxygenated more appropriately because the fluid isn't blocking off oxygenation in the lungs. From there, just like the last one, you want to do your chest pain management. Of course, always do the 324 milligrams of aspirin PO, have them chew it up if they can. From there, you want to go ahead and do 0.4 milligrams of nitroglycerin SL every 5 minutes, as long as that blood pressure remains over systolic to 90 to 100. Now, we're also doing the nitroglycerin to help make the heart not have to work as hard. It helps reduces the workload of the heart. And you can also do the nitroglycerin paste as well if it's above systolic to 90 to 100. Like I said, as we get into this, we're going to go ahead and talk more about the dosing of nitroglycerin paste. You do still want to make sure the patient has a good blood pressure, and same thing with CPAP. Even though CPAP is the best intervention you can really do for a severe CHF exacerbation, you want to make sure their blood pressure is still above around that 90 range. That's because CPAP can lower the blood pressure, and you don't want to make this patient have even less perfusion to the body or to the heart. Then you can also go ahead and give a 1.25 milligram dose of enalapril IV. That's an ACE inhibitor. I'll also go into more detail in a couple minutes about that medication, but it is amazing for congestive heart failure patients, especially if they have a lot of fluid buildup. Then finally, NCOEMS protocols state that you can do 40 milligram furosemide IV. Furosemide is a Lasix. Before it was kind of a cornerstone treatment of CHF. Now they've kind of taken a step back and added a couple limitations to make sure that we're not having any serious adverse effects with it. So the three big ones is they say, first, the transport has to be longer than 30 minutes. They don't want you doing a New Bern Avenue to Wake Med Raleigh. That's about a 5-minute drive. If you're not familiar with Raleigh, they don't want you to do a 5-minute trip just to get to the hospital and giving the Lasix. They also say that the patient should already be taking a Lasix daily, and the patient also should be afebrile. So very important to check the temperature if you're having a long trip with a patient who already takes Lasix, even if they haven't taken them that day, because Lasix is just another great way to get fluids off of the body, which CHF unfortunately holds on to along with sodium. And now the last of the three of the acuity levels for the NCOEMS state protocols is cardiogenic shock. Like I said earlier, this is what I was describing when I said the severe CHF exacerbation. This is when basically the pump goes from barely working to complete failure. So this is a good indicator that the patient is in cardiogenic shock is they begin the call with hypertension, and then it does follow with pretty severe hypotension, and they also begin the call with tachycardia, following by severe bradycardia. This is signs of severe digression of congestive heart failure. This is what we try to, take care of the moderate to severe and even the mild CHF exacerbation as quickly and effectively as possible, so we do not get to this point. Like I said earlier during this lesson or lecture, that there is a mortality rate of about 70%, even with the aggressive treatments. So going into treatments, like I said, we're going to have to do everything we can. Once you do notice that it does look like cardiogenic shock, you don't want to waste any time on your treatments either. So big thing with the treatment is you want to go ahead and remove the CPAP and the nitroglycerin paste if you can. This is because CPAP, like I said, can lower the blood pressure. Nitroglycerin paste is also a vasodilator, so both of those can have that active effect of lowering the blood pressure. The blood pressure is already to the ground. You do not want to do anything else to make that even worse, because there is barely any perfusion going on to the body at this point. It is optional. Obviously, with a patient with congestive heart failure, we're trying to keep fluids away from them, but it would not be the worst idea to go ahead and do that 500 milliliter normal saline bolus. like I said, this is a very high mortality rate condition when it does happen, so it's not really the worst idea, because if the patient does improve from that, you can always just put the CPAP back on, hopefully, and the furosemide, and enalapril will also help keep the fluids off if the saline bolus does work. Now, if the saline bolus does not work, or you decide not to use it, they do say go ahead and go into vasopressors for treatment. The one that I've seen the most recommended for cardiogenic shock for congestive heart failure is Levophed. You want to go ahead and do that 2 to 30 mics per minute, and you'll want to go ahead and put a 4 milligram Levophed dose into 250 normal saline bag. In a couple slides, we'll talk more about how to do the drip and how to exactly calculate your drip rate. So in this part of the lecture, we're going to watch a couple videos that I did at the Wake Tech East campus. I want to say thank you to Dr. Sandy Hunter and Raven Hutto for helping me out to be able to do these videos for this project. The first video is going to show CPAP application and how to also do an inline nebulizer. Second one is going to go over the chest pain protocol, showing some of the ALS sides of it, along with how to do the nitroglycerin paste and the dosing associated with the paste. Then we're going to go over how to do the Levophed admin, just show how to do the infusion. I know some people aren't too familiar with infusions. It isn't something we do very commonly in EMS when you think of the day-to-day schedule, but it's something that when we do it, it's very important that we do right, especially in the use of a vasopressor to be able to increase someone's blood pressure, heart rate, and such. And then finally, we're just going to talk about how to do the enalapril admin, and then also talk a little bit about enalapril and why it's so good for patients with CHF. I believe these skills are essential for a paramedic who's leading a congestive heart failure call. I think having all these skills and making sure that you master these are going to be very important to be able to make sure the patient will get the best care possible. So for these next 4 videos, it's just going to be pre-done videos. We're going to be talking about the CPAP application on a patient. For a patient with congestive heart failure, it's very important to get a patient CPAP very quickly. It can help push the crackles and fluids down on the lungs to help open them up, and also keep the blood pressure down a little bit. It is important to make sure the patient is at least normotensive, so make sure they at least have a blood pressure systolic 90 to 100. It's also important to talk to the patient before you apply the CPAP. It is a lot of air being blown to them at once. It's kind of like sticking your head out the window while going 70 miles per hour on the highway. Some patients do benefit from a 1 to 2.5 milligram dose of Versed, help calm them down. We don't have the inline end tidal, unfortunately, so we're doing the nasal cannula end tidal. This doesn't have any oxygen flowing right now. It's just allowing us to see what patient's respiratory rate is along with their end tidal CO2. So first, you want to go ahead and make sure you have the CPAP all set up. We have the little head covering one. Make sure it's all connected. Then you want to hook it up to oxygen. You want to do it the liters per minute adjusted with the PEEP setting. I'll put a picture of the chart up here. So we'll go ahead and start with a PEEP of 5. So we're going to put that 8 liters per minute. We'll make sure that we got the air blowing correctly, and then we'll just kind of talk the patient through putting it on. You don't want to just shove it on them and scare them. So we'll go ahead, put the mask on. You want to have a good seal. Some patients with larger faces or also with beards, it might be hard to get a good seal, but you want to do your best to make sure that all that air is being pushed into them, not outside the mask. So we'll get a good seal, clip it on, tighten it as so. And there we go. That's how we have the CPAP applied. Now we're going to talk about how to do the inline neb. Before, using a nebulizer was kind of contraindicated for patients with congestive heart failure, but a lot of these patients, they might also have COPD or other respiratory illnesses, so they might be having this CHF exacerbation going on, but they might have some wheezing or bronchospasms going on. So sometimes it is beneficial to go ahead and give them the albuterol or duoneb. Important thing with that is you want to make sure that the nebulizer has its own set of oxygen. You don't want to just hook it up to the other one. It is also important to note with the CPAP, if you're using a small D tank, that it runs through oxygen fairly quick. So you want to make sure you either have another D tank on hand or you're ready to switch the patient over to the main tank eventually. So to put the patient into the inline neb, you want to go ahead, you have your nebulizer, have it hooked up. You want to go ahead and get your medication, open it up as so, open up this right here, squeeze the medication in, obviously do your med check, make sure it is not expired and you're doing it the right route, right dose, and all that good stuff. So then we'll close it up. We'll go ahead and hook it up. I have another oxygen supply right here. So we'll put right here, we'll go ahead and set it to about 8 liters per minute. You'll start hearing, you'll start seeing the nebulizer kind of start to atomize when you do that. And then you'll just put it right here, just like that. Like I said, it's important to make sure that you have 2 lines of oxygen going, one for the CPAP, the other one for the nebulizer. Kind of talk the patient through it while you're doing the CPAP, especially when you are doing the inline neb. It's important to listen to lung sounds every 5 minutes. There have been cases with the albuterol where you can get the pink frothy sputum kind of coming up from the mouth. Like I said, it's not very likely, but it is a possibility. So you want to be a little careful while doing the albuterol, but if they have other respiratory illnesses and you can hear some wheezing in the upper lobes, it will probably be a good idea. But this is how you apply CPAP, especially with the inline neb, and make sure you have the end tidal. Thank you guys. Hello everyone. So we're just going to go over the chest pain protocol real quick. Obviously patients with congestive heart failure, they are known to have chest pain, and it's important to make sure that, along with helping putting the CPAP on and helping opening up the lungs and push down the crackles, to take care of that chest pain. So obviously first thing you want to do with chest pain, you want to give the aspirin. You're going to give 324 milligrams. So that's usually, they come in 81 milligram tablets. So you'll just open it. You'll take out 4 tablets or so. You want to make sure that this is not expired. You want to make sure that this is the right route you want to give it, to the right patient, and this is the right dose. So we'll have these 4 chewable tablets right here. I don't know if you're able to see them, and you'll just have that patient chew it real quickly. Once you give that patient the aspirin, or you could also have your EMT give the aspirin, you want to go ahead and start going to the nitro. Now, nitroglycerin, it can lower the blood pressure. You also want to make sure that the patient is not taking any erectile dysfunction meds, because that can also tank the blood pressure as well. So you can go the SL route, sublingually. You can also do the nitro paste. So we'll go over the sublingual route first. So you want to give 0.4 milligrams. You want to make sure, of course, it's not expired. This is in 0.4 for every tablet. So we would open this up. We would take one of these tablets right here. It's a real small tablet, and then we'll just have that patient put that under their tongue and let it dissolve. It's important to keep an eye. Some patients, they do get headaches from getting the nitroglycerin. But let's say, we gave them that aspirin nitro at first, it's a congestive heart failure patient. We went ahead and put the CPAP on. It might be a good idea, instead of taking the CPAP on, let's say 5 minutes have passed and they're still having chest pain, instead of doing another sublingual nitroglycerin, you can go ahead and go to the nitro paste. So nitro paste is fairly simple. It usually comes in a sheet like this. You can do up to 2 inches. You have this right here. This is a nitro paste. You do want to do it off of the patient's blood pressure. So if a patient has a systolic blood pressure of 100, you want to do 1 inch. If it's 150, you want to do 1.5 inches. And if the patient's systolic blood pressure is over 200, you want to do 2 inches. So for the case of this, we'll go ahead and say the patient does have a systolic of 200, and you just want to do an equal amount, spread it across this sheet right here, across the 2 inches. Same thing as the other medications. You want to make sure it's not expired. You want to make sure you're doing the same dose. As I said, we have it right here. We got the 2 inches. We made sure that it's not expired. We made sure the patient's blood pressure is 200 systolic. And then you just want to place it somewhere on the upper chest. So we'll go ahead and place it right here. You have it set right there. Obviously, you still want to keep on monitoring the blood pressure. If the blood pressure does start to drop down, it's important. So as I was saying, you want to keep an eye on the blood pressure when you have the nitro paste on. If the blood pressure does get too low, you can always just take the nitro paste off like that and then wipe it off the skin. So once you do that, you can continue to keep the nitro paste on. Let's say you have done the aspirin, you've done the nitro SL, you've done the nitro paste, and that patient is still complaining of 10 out of 10 pain. It is up to you. You can go ahead and go to fentanyl. Fentanyl is good for pain management. It's also known not to drop the blood pressure too much. So maybe if you have a patient where you gave them the nitro, their blood pressure went down, but they are still in excruciating pain, you can go ahead and give them a fentanyl dose. Obviously, you want to get IV access by this time. You want to do it in 50 microgram doses. So right here we have fentanyl, same thing. You want to make sure you're giving the right dose. It's not expired. You pull it up. Right here, our concentration is 100 mics and 2 mLs. So we're going to be given 50 mics. So I'd go ahead and draw up 1 ml here. So go ahead and draw it up. And you'd want to flush the line first, and then you just want to slowly push the fentanyl into the IV line. And then also along with that, when you flush it after, you still want to do a slow push because that fentanyl is still in the vein there, so you don't want to just shoot it up after you slowly put it in. But that's the chest pain protocol. Like I said, most of this is BLS besides the ability to continue to give the nitro every 5 minutes as long as the patient is normotensive and the additional fentanyl. Thank you guys. So for this skill, we're going to be talking about how to do infusions with the bag. Primarily, we're going to be talking about how to do it with the vasopressor. So we got Levofed here. It is the common medication used for cardiogenic shock and congestive heart failure after it starts with hypertension, followed by hypotension, and tachycardia, followed by bradycardia. So first, you want to open up everything. Like every medication, you want to make sure it's in date. You also want to get the line. This one I have is a 10 drop for all medications infusions. You do want to use a 60 drop. You have everything set up. So when you've done any IV bag, obviously you know this one you take off. This is what you put the line in. But this right here is what we're going to do the medication through. So we're going to first take the medication, make sure it's not expired. What we're going to do, we're going to put 4 milligrams in this 250 bag. Right here we do have a 3 ml syringe. So I'm going to pull up 3 mLs, put it in here, and then I'm going to pull up that extra ml. Because right here we got 4 milligrams for 4 milliliters. So we'll go ahead and pop the cap here. And we'll pull this out like this. Got it, 3 mLs. And we'll just put it in. So be careful when you're working with sharps and medication with your gloves. So you're gonna push that air in, and that should go ahead and fill it up. Slowly but surely. Pull it up, get any fluid that might still be in the syringe there, cap it off. If you see right here, there are some bubbles at the bottom, so I'm going to try to tap it to get those bubbles out. There we go. Sometimes you can just shake it. See, it's important to get those bubbles out because you don't want to get any fluid or air in the line. So I got my 3 mLs right here, so it's 3 milligrams right here. Take it out. Obviously in a different one, take it out there, put the needle, and then in your bag here, you're going to inject it right here and push it through. So I'll go ahead and visualize it to y'all. You want to try to do in the center point, push it in. There we go. And as I said, we're doing 4 milligrams in a 250 bag. So we put 3 mLs in. We'd obviously switch this to a different one, pull this out, and then the vial we have here, we would just go ahead and try to drop our last milliliter. Push it in, draw it up. There we go. Same thing, pull it up, try to get any air out the bottom of the syringe here. There we go. And we got 1 milliliter right here. Go ahead and switch this to the different one. And then we'll go ahead and put the last milligram into this bag. So like I said, you just want to put it in the center here. If you have a longer needle, you want to make sure that you don't puncture the plastic part right here. And there you go. So you got the medication in there. Cap this off, put this in sharps. Be a good idea to mix it up since you got the medication in there. You know, just like you're mixing up like a smoothie or Gatorade or something. So then you want to take your line just as you would do with any fluid. Pop this part off right here. Take it as such. Give me 1 second, let me get a trash bag. So sorry about that. So, you got your line right here. I'll go ahead and tangle it out. Make sure it's obviously clamped up. And then you want to go ahead and get all the air out of the line here. Just like with a regular line, I'll make sure there's no air. So go ahead and take this all out and open this here. Just do it. Obviously, once you take off the cap, you want to make sure you're keeping it sterile as this is going directly into the IV. So we got the fluid coming out of it. We'll go ahead and clamp that off. At this point, you would want to go ahead and get a little set up. Go ahead and insert it into the line. You do want to make sure the line is patent. It is important. Probably a good idea to do at least an 18 or 20 gauge IV. Though if 22 is the only thing you can do, that's the only thing you can do. So we'll go ahead. And so we're going to go ahead and we want to do 8 micrograms a minute. I'll put the chart up that I use, so that's about 30 drops a minute. So we're looking here is a drop every other second about. 1, 2. So I say that's about a drop every 3 seconds. 1, 2, 1, 2. So I say right here, we're doing probably about 30 drops a minute. It's looking like it's about a drop every other second. Like I said, I am using a 10 drop. I don't have access to 60 drop, so it'll be a lot easier to kind of calculate the drops per minute when you have a smaller gauge that's going through. But that's how you do the IV infusions. Pretty simple, but it's important to make sure you do that right. You're doing the right dose, you're putting the right amount of medication in so the patient is able to get that vasopressor so the blood pressure is be able to get increased. But thank you guys. So now we're just going to talk real quickly about enalapril. I don't have the actual medication. We'll pretend like this is enalapril. It's pretty much the vial it comes in. Enalapril is an ACE inhibitor. It's used to help reduce blood pressure while increasing output of fluids and urine. So when you have a patient with congestive heart failure, usually their blood pressure is through the roof, it's also, they're having that difficulty with fluid retention. So giving the ACE inhibitor will help lower the blood pressure. It might not be immediate, but at least within the next couple hours, help lower the blood pressure and also help push out some of these fluids that the patient is holding on. Thank you, guys. So for our first scenario, it is going to be very low fidelity, almost like a tabletop scenario. So we'll kind of talk through it together. I still want you to take it seriously. I still want you to try your best, but here we go. So your conscious and alert diaphoretic 55-year-old patient presents with shortness of breath and severe chest pain and a history of congestive heart failure. Patient's vitals are blood pressure 180 over 100, sinus tach, a pulse 140 beats per minute, got SpO2 of 86%, respiratory rate 30 times a minute, lung sounds or crackles in all fields, you got temperature 97.8 and a blood sugar of 101. So I just want you guys to identify the level of severity the patient is displaying, create a treatment plan in line with the NCOEMS state protocols. To receive full credit, I want you guys to provide the correct dosage of all medications. So you guys can go through that, and then after that, I'll give you guys some feedback and let you know the answers that I had and make sure there wasn't anything you guys missed. So looking back at the scenario, all of y'all's answers probably had a lot of the big aspects. The big thing is making sure that you're taking care of the ABCs. First off, per NCOEMS protocol, the patient is in moderate to severe CHF exacerbation. For treatment, you want to go ahead and do the 324 milligrams of aspirin chewable, get them on the CPAP or BiPAP if you have it. You got to do the 0.4 milligrams nitro SL. You can repeat that every 5 minutes if chest pain persists and the patient remains normotensive. And or you could do the 1.5 inches of nitroglycerin paste. Might be a better route once you do the CPAP or BiPAP, just so you don't have to have them take the mask on, put the CPAP on, take the mask back off. You do want to go ahead and do emergent or rapid transport after you stabilize the patient. Lights and sirens, it's optional. You guys probably seen some studies where it hasn't been too helpful compared to just going regular traffic to the hospital. You do want to go ahead and establish IV access. You want to go ahead and do the 1.25 milligrams of enalapril IV. Other ACE inhibitors are okay too if your agency allows them. I've only known using enalapril. Do the patient notification report to the hospital, and then some kind of optional or extra credit things. Like I said, we left it a little open for you guys to add in. If you asked if the transport time was longer than 30 minutes and the patient was afebrile, you could have given them furosemide 40 milligrams IV. And with the patient, you could have talked about doing some verbal coaching and if possible, or if needed more so, 1 to 2 milligrams of midazolam or Versed IV if the patient is not complying with the CPAP. So now that we did a little basic scenario practice, we went over the causes of CHF, the symptoms of CHF, and how to treat those said symptoms and how to do the skills. We're now going to do a little bit of a high fidelity simulation. This is going to be kind of the intermediate ALS level of how to do it. This next slide is going to be me going through a scenario that I created myself, and then the slide after that we're going to be discussing treatment plans and what things you do need to do within a certain time. This is oriented for you guys. This is our first day fundamentals of congestive heart failure, so some of the time constraints are giving you a little bit more leeway than you will whenever TSOPs come around or you have your final scenario on CHF. So for this part, we're just going to go over a high fidelity scenario. Could also be used for a tabletop scenario. Obviously, this is an online lecture. I'm not going to be able to give you guys full out high fidelity scenarios, but you would obviously have your full jump bags. We would do it in a setting where either you're talking straight to the mannequin or we're in a different room and we're able to talk to you through a microphone and a speaker. But we'll just, I'll give you the rundown of it and then we'll talk about it after. So you're dispatched at 8 a.m. to a one-story house. You're 15 minutes away from the closest hospital, dispatched to a 40-year-old male, 220 pounds, with chest pain and shortness of breath. Scene is safe. You got the gloves. The mask and eyewear is optional. Might be a good idea if the patient is having that respiratory illness. Nature of illness is respiratory, but it is also cardiac as well. Additional resources, you can probably go ahead and have fire come. C-spine is not indicated since it is not an injury. Your general impression is a 40-year-old male in tripod position sitting in chair. Patient statement to you was, I woke up this morning with severe chest pain and shortness of breath. Patient is alert. I said chief complaint, shortness of breath and chest pain. Airway is open and patent. Patient is breathing 30 times a minute, rapid, but they are deep respirations, so they're not shallow. Lung sounds or crackles in all fields, equal chest rise and fall, increased respiratory effort and decreased air movement. Circulation, there's the radial pulse is present, rapid and weak. Skin color, temp and condition, pale, cool and clammy and diaphoretic. Is no major bleeding or injury. And then you would make your transport decision. For me, I put stabilize, load and go. And then just, you go ahead and do your assessment. Say, if you haven't by now, go ahead and put this patient on high flow oxygen. Go ahead and get a 12 lead. You can go ahead and put the CPAP on as well. Looking at the history of present illness, patient looks like the patient's difficulty breathing has been progressing for the past week. Sharp pain upon waking up this morning. Laying down makes the breathing worse. Tripod position is comfortable for him. Has a sharp chest pain, crackles in all lung fields for lung sounds. The pain radiates to the left axillary area. Severity is 10 out of 10 left side chest pain, 9 out of 10 shortness of breath. Got the chest pain for about an hour, shortness of breath for about a week. Non-compliant prescribed medications, aspirin, nitroglycerin for chest pain, and enalapril for about 2 weeks as he ran out. He does take furosemide, but he's not taking it today. No erectile dysfunction medications. Congestive heart failure is the only past medical history. He does go to a cardiologist and a pulmonologist at Wake Med Raleigh, Dr. Cardiogod and Dr. Lung. Goes to each doctor once a month. He ate last night. He did drink about 8 ounces of water this morning. No lifestyle changes besides non-compliance with medications. Says shortness of breath has been going on for about a week, as I was saying up here for a time, but has gotten progressively worse. And the dual usual chest pain he had was a sudden onset of severe chest pain this morning. Was a former smoker and does have a family cardiac history of CHF. Going quickly through the cardiovascular secondary assessment, has a chest pain, tachycardia, hypertension, does have increased urination. For pulmonary, shortness of breath, crackles in all fields, decreased air movement, increased respiratory effort. And then quickly going through the vitals, he has a pulse 130. That if you look at the bottom here is sinus tach. Blood pressure 200 over 100, SpO2 88%, end tidal of 30, respiratory rate 30 times per minute. Lung sounds are crackles in all fields with increased respiratory effort and decreased air movement. Blood sugar, temperature, and alertness is all baseline. But his skin color is pale, cool, clammy, and diaphoretic with pedal edema. So looking back at that scenario, first you just want to make sure that you didn't hit any of the critical criteria, or you didn't miss any of the critical criteria that would make you fail the scenario. And then you can look here at the treatment or interventions that are required. Missing any of these would also be a critical failure. So you want to make sure you do your ABCs, proper assessments, and vital signs within 10 minutes. You also want to do the rapid CPAP at a minimum PEEP of 5, which would be 8 liters per minute within 10 minutes. You also want to do the rapid 12 lead within 15 minutes. And all of these, it really would be better if you get all those within 5 or 6. But as this is just the starting out scenario, we're not going to go too hard. This is not your TSOP, but when we do get to the TSOP setting, it will be a lot shorter time that you have to get all this done. For medications, we'd want to do 324 milligrams of aspirin PO chewable. You want to do the 0.4 milligram nitroglycerin SL or the paste every 5 minutes if normotensive. Starting off with the paste, if it's 200 over 100, you'd want to do the 2 inches on the chest. You want to go ahead and establish IV access, 1.25 milligrams of enalapril IV. Repeat assessment and vital signs. And it is optional where you could do the 50 to 100 mics of fentanyl IV or 4 milligrams morphine IV if chest pain persists. So the important thing is you want to make sure that you're treating the chest pain, you're putting the CPAP on, you're making sure the patient is in an MI or a deadly arrhythmia by putting on the 12 lead. We can just quickly go through some stuff. I said treatments are here. See the patient on the 12 lead, their sinus tach. We can look at the condition, proper treatments provided. That would decrease the blood pressure, increase the SpO2, decrease the respiratory rate, increase the end tidal, would help with the lung sounds and air movement, and would help a little bit with the sweating. Patient isn't diaphoretic. Obviously right here is if you didn't do the scenario correctly, what would happen to the patient. The patient would continue to deteriorate. More information of what you do if you did it right compared to what you did it wrong. And yeah. We are almost done. I know you guys are probably getting sick and tired of looking at my face and hearing my voice. We're going to take one more 5-minute break. After that, we're going to do another high fidelity scenario, except it's going to be a little bit more advanced with some CHF deterioration that will happen, and we'll also talk about before we do the scenario. But go ahead, take your break, and then we'll go right back to it. Hope you guys enjoyed your break. Like I said, in the final part of the lecture here, we're going to be talking about CHF deterioration. I'm going over Objective 5. Students will identify deterioration of a CHF patient and modify the treatment plan to stabilize the patient with at least 80% accuracy and high fidelity simulations without critical error. So before we do the scenario, like I said, we'll just talk about a couple things real quick. So CHF can cause cardiogenic shock if untreated, which can lead to hypotension after previously hypertension, bradycardia after previously tachycardia. For treatments, the Levophed drip is indicated for cardiogenic shock. You do that for the 2 to 30 mics per minute. Put the 4 milligrams in the 250 bag. 500 milliliter fluid bolus is okay too, but admin with caution. Do understand you probably were having the crackles in the lungs, so giving a bunch of fluid isn't really the best bet. CPAP and nitroglycerin can also cause hypotension. So if the patient does start to deteriorate and they're showing cardiogenic shock, one of the first things you should do with whoever is with you in the back is remove the CPAP and the nitroglycerin paste if it's applied, if the hypotension occurs. And also, if you've already given a report, definitely let the hospital know, give a little heads up. Hey, this patient just, went 0 to 100, or, probably better saying 100 to 0, and, the patient's starting to get a little worse. So for this scenario, we're going to use the high fidelity same scenario that I had before, for tabletop scenario of it. The 40-year-old male online lecture. I'm not going to be able to give you guys. I'm not going to play it here, but you can go back earlier in the video. You'd obviously have your full jump bag. Read my discussion of that scenario setting where either, and then we'll just add a little talking straight to the mannequin, or we're in a different room and we're able to talk to you through a microphone and a speaker. But we'll just, I'll give you the rundown of it, and then we'll talk about it after. So you're dispatched at 8 a.m. to a one-story house. You're 15 minutes away from the closest hospital. Dispatched to a 40-year-old male, 220 pounds, with chest pain and shortness of breath. Scene is safe. You got the gloves. The mask and eyewear is optional. Might be a good idea if the patient is having that respiratory illness. Nature of illness is respiratory, but it is also cardiac as well. Additional resources, you can probably go ahead and have fire come. C-spine is not indicated since it is not an injury. Your general impression is a 40-year-old male in tripod position sitting in chair. Patient's statement to you was, I woke up this morning with severe chest pain and shortness of breath. Patient is alert. I said chief complaint, shortness of breath and chest pain. Airway is open and patent. Patient is breathing 30 times a minute, rapid, but they are deep respirations, so they're not shallow. Lung sounds or crackles in all fields, equal chest rise and fall, increased respiratory effort and decreased air movement. Circulation, there's the radial pulse is present, rapid and weak. Skin color, temp and condition, pale, cool and clammy and diaphoretic. Is no major bleeding or injury. And then you would make your transport decision. For me, I put stabilize, load and go. And then just, you go and do your assessment. Say, if you haven't by now, go ahead and put this patient on high flow oxygen. Go ahead and get a 12 lead. You can go ahead and put the CPAP on as well. Looking at the history of present illness, patient looks like the patient's difficulty breathing has been progressing for the past week. Sharp pain upon waking up this morning. Laying down makes the breathing worse. Tripod position is comfortable for him. Has a sharp chest pain, crackles in all lung fields for lung sounds. The Pain radiates to the left axillary area. Severity is 10 out of 10 left side chest pain, 9 out of 10 shortness of breath. Got chest pain for about an hour, shortness of breath for about a week. Non-compliant prescribed medications, aspirin, nitroglycerin for chest pain, and enalapril for about 2 weeks as he ran out. He does take furosemide, but he's not taking it today. No erectile dysfunction medications. Congestive heart failure is the only past medical history. He does go to a cardiologist and a pulmonologist at Wake Med Raleigh, Dr. Cardiogod and Dr. Lung. Goes to each doctor once a month. He ate last night. He did drink about 8 ounces of water this morning. No lifestyle changes besides non-compliance with medications. Says shortness of breath has been going on for about a week, as I was saying up here for a time, but has gotten progressively worse. And the dual usual chest pain he had was a sudden onset of severe chest pain this morning. Was a former smoker and does have a family cardiac history of CHF. Going quickly through the cardiovascular secondary assessment, has a chest pain, tachycardia, hypertension, does have increased urination. For pulmonary, shortness of breath, crackles in all fields, decreased air movement, increased respiratory effort. And then quickly going through the vitals, he has a pulse 130, that if you look at the bottom here is sinus tach, blood pressure 200/100, SpO2 88%, end tidal of 30, respiratory rate 30 times per minute. Lung sounds are crackles in all fields with increased respiratory effort and decreased air movement. Blood sugar, temperature, and alertness is all baseline. But his skin color is pale, cool, clammy, and diaphoretic with pedal edema. So like I said, just once you go through that scenario, treat it just like you would in another high fidelity. Do the whole thing top to bottom, and then at the end, when you start transporting to the hospital, we'd add this part. So after initial treatment and beginning of transport to the hospital, patient heart rate decreases to 45 and blood pressure decreases to 70/45. Repeat 12 leads shows sinus Brady with ST elevation in leads 2, 3, and AVF. Identify what happened to the patient and modify your treatment plan that is still in line with NCO EMS state protocols. Provide the correct doses of any medications you may use for full credit. So like I said, we'll just add that to the scenario, so same thing, and then after that we'll just do a little feedback on it. So after doing your scenario, some of the answers may vary, but the important things it should include is that the patient was in cardiogenic shock with an inferior MI, remove the CPAP and remove the nitro placed if you did apply it, the 500 milliliter fluid bolus, whether that's lactated ringers or normal saline, is optional. And you want to go ahead and do the vasopressor. So what I've always been taught is to do the Levofed. So you want to do that Levofed 2 to 30 mics per minute. Make sure you do the correct dosage, 4 milligrams in a 250 ml bag, and do that until you can get a systolic blood pressure of at least 90. From there, if you weren't already doing it, go ahead and do emergent code 3 to the hospital, and then do another patient update report to the hospital. Let them know that this patient seems to be in cardiogenic shock and they're now on a vasopressor. Okay, well, this is the end of the lecture now. It's time for the lesson assessment. Before you guys take it, thank you guys again for watching my lecture. If you guys want to take some time real quick to go back through it, make sure there's anything you didn't miss, go ahead. But during the lesson assessment, please don't look back at the lecture, as that would be cheating. Just to give you a heads up of how this assessment's going to go, it's 20 questions. There's going to be 4 questions for each objective. For the objective 1, 2, and 3, you can only miss 1 question. Since it's 4 questions, to maintain a 75%, you need to get at least 3 of them right. For objective 4 and 5, for those 4 questions, there is 1 essay question for each of them. Just a heads up, but as long as you've been paying attention and you either did a scenario or you got feedback or watched how someone else did their scenario, you should be fine. The next 2 slides are going to be the assessment for you to take and then the answer key after to look after. Obviously, if I had you guys all here right now, I'd be able to hand you either a written test or set up a test on a Blackboard or another website like Canvas. But good luck, you guys. Good job, everyone. It looked like everyone passed, so good job. We're just going to go quickly through the answer key. Feel free to pause at any moment just to look through any questions you might have gotten wrong, but good job. We had everyone pass, so that's amazing. Perfect. And to wrap up our lecture, I do have a little handout for you guys. It's just a simple CHF pharmacology handout. You just do for the CPAP, nitro, nitropase, enalapril, and furosemide. Just do the indication, dose, contraindication, MOA, and adverse effects. Now, if you give me 1 second, obviously don't look at this until you finish doing this handout. When you do, I'm going to go ahead and swap it over. This does have the answer key here. Obviously do this by yourself first, and then after that you can look back and check your answer to make sure it's correct. And that's it. I do want to thank you guys so much for your time. I know this was a little lengthy lecture. I know it was a little inorganized at some times, but thank you so much for listening. I hope you were able to learn a thing or two about congestive heart failure, how to treat it. Like I said in the beginning, this is just the fundamentals and foundations. It would be a good idea to keep on studying CHF and getting a deeper understanding, but just for the time we had, I wanted to get you kind of an expert at the ALS basic stuff. So thank you guys so much. And just one extra slide, just saying thank you to the sources I used for this presentation. Relied heavily on the Sanders Paramedic Book 5th edition and the Nancy Caroline Emergency Care in the Streets 7th edition. Also used the NCOEMS state protocols along with some infographics I found online that I really liked. You guys have a good day.